I love my work. I'm not working on something that may or may not give results. I know when I get out of bed in the morning, I can make a difference. My name is Pierre Blier, and I'm the director of the Mood Disorder Research Unit at IMHR. The burden of depression is going to keep rising in the next 15 years. So we need to do something. We need to change the course. And you cannot change the course with the way depression is being treated, because the burden is increasing. So by having a depression research center, we're going to be testing new approaches, measure it against what's going on right now. So we want to try to build on this because we want to reverse that grim prediction. In the context of our treatment resistance study in brain volume, we treated 28 patients very aggressively, and about half of them we were able to obtain a sustained remission over 6 months. And some of these patients had failed 6, 7, 8 treatments before, so that's a direct impact. What we're going to be doing in one of the trials that we have started is to take patients who are referred to the hospital. They will be assessed by a psychiatrist in the mood disorder clinic, and then from then on we'll genotype them for specific genes, and then we will randomize them either to the tertiary care center as usual versus an intensive pharmacotherapy arm where patients are going to be seen every 2 weeks. We're going to be changing doses of medication, regimen in case they don't work, because 2 weeks is long enough to determine if something is going to work or not. So it's going to be much more intensive. And then in case of emergency, for example, when patients are extremely severely depressed or if they become suicidal, the usual conduct is to hospitalize them and to give them electroconvulsive shock treatment. Instead, in our unit, we would be doing ketamine infusion. Ketamine is an anesthetic agent that we use at minute doses that don't put people under. And we've done here so far about 125 injections in patients, and with very good results. Most patients can respond very rapidly. Within an hour, they can have a robust antidepressant effect. That's the good news. The bad news, why we have to do more research on it, is that in some people it can last 24 hours or it could last up to a month. So we're going to try to characterize the response and what may predict it or not. What I would like to see is more funding for the basic research, because we are, like I said, taking these observations into the clinic. So more resources, perhaps more imaging, and be able also to convince people that even with what we have now, we can make a big impact, improve the outcome for the treatment of depression, and not continue with the old ways.